I think we can get started. Hi, everybody. Thank you for coming on the evening before a long weekend. Thanks for joining. I'll start off with my little description about the CFAR seminar series and then introduce our speaker for today. The CFAR seminar series provides a forum for presenting and discussing state-of-the-art research findings in HIV pathogenesis, virology, care, and treatment, and to provide an opportunity for enhanced communication and multidisciplinary collaboration among HIV/AIDS researchers across the 5 CFAR affiliated institutions and their partner organizations. I'm very pleased to introduce today's speaker, Dr. Christopher Longnecker. Dr. Longnecker earned his medical degree from the Ohio State University. He trained in internal medicine at UCSF and in cardiology at University Hospitals of Cleveland. He was on faculty at Case Western for 8 years before joining the University of Washington in 2021. He's currently associate professor in the Division of Cardiology and Department of Global Health in the UW School of Medicine. He's the director of the Global Cardiovascular Health Program, a joint initiative of cardiology and global health. He attends on the Harborview Cardiology Service, and he's the director of a unique HIV cardiology clinic within the Madison Clinic at Harborview. Dr. Longnecker's research is primarily conducted in the US and in Uganda, and it focuses on mechanisms and prevention of cardiovascular disease in people living with HIV, with a secondary focus on quality of care and outcomes for people living with rheumatic heart disease. His research has been funded by the NIH, the American Heart Association, and Medtronic Philanthropy. Today, he's going to talk to us about cardiovascular risk in women with HIV. Thank you so much for coming. Looking forward to your talk.
Great. Thank you so much, Pavitra, for that kind introduction. It's a pleasure to be here today. Even if the group is small, I think it's going to be a great opportunity to talk about cardiovascular risk in a unique group of particularly women with HIV. A couple disclosures before we get started. So this was a talk that I originally put together for the KRTC group. So if you attended that, my apologies if a lot of this is very similar with a few updates. And secondly, I'm going to be talking primarily today about cisgender women with HIV. I want to recognize there are a lot of potential issues to consider in transgender men and women related to cardiovascular risk. Unfortunately, the research in that area is not as robust. So if anyone needs to get a hold of me, here's my contact information. You can follow me on Twitter at HIVCardioDoc. All right. So we know that no one in this room needs reminding that there are 38 million people living with HIV around the world, or frankly, that the vast majority of the burden is in sub-Saharan Africa, where I do work in Uganda. But it's just helpful to remind everyone that the burden of HIV/AIDS in sub-Saharan Africa is felt disproportionately among women. You can see the male to female ratio there across the world, and sub-Saharan Africa, females outnumber males. And so I think when we talk about cardiovascular risk in women with HIV, we want to study that in places where women with HIV live, and that's sub-Saharan Africa. We've seen a decline in new cases and deaths, obviously, throughout the region, throughout the world, because of access to antiretroviral therapy. But as a result of this, clearly as HIV/AIDS mortality has gone down over recent years, we have to see something taking its place proportionally, and that's this rise that we see in non-AIDS comorbidities, such as cardiovascular disease. And in this slide that Steve Grinspoon created originally, that summarizes epidemiologic data for an increased risk of myocardial infarction or coronary heart disease, you can see that risk associated with HIV infection appears to be about 1.5 to 2-fold. But all of these studies primarily have been conducted in the United States or high-income countries such as France or Denmark. And whether this magnitude of risk is the same in sub-Saharan Africa is also not quite known. But when we consider the population impact of HIV on CVD burden, it doesn't just matter what is the relative risk associated with HIV, but the prevalence of the risk factor within the population also contributes to population impact as well. So we, in 2018, together with collaborators at the University of Edinburgh, used global burden of disease estimates and a meta-analysis of the HIV effect to try to estimate the global burden of ASCVD due to HIV. And these are population attributable risks across different countries. And you can see that in sub-Saharan Africa, in some countries, up to 15% of all ASCVD was thought to be attributed to HIV. In estimates that we produced here in the supplement table, you can see that in Uganda, the estimate for the population attributable fraction was about 4.8%, similar to other countries in East Africa, but much lower actually than countries in Southern Africa where HIV prevalence is higher. And this is in contrast to countries like Pakistan or Kazakhstan, where CVD burden is very high, but because HIV prevalence is low, HIV-related CVD is relatively lower. So it's not just atherosclerotic coronary artery disease or stroke, but heart failure, and that could be ischemic heart failure, but could also be heart failure due to AIDS cardiomyopathy, could be heart failure due to HFpEF or other reasons, is also appears to be increased in people living with HIV compared to matched controls. These data from the VA, it does appear to be higher. The risk is higher in younger people, particularly for heart failure with reduced ejection fraction compared to heart failure with preserved ejection fraction. So in a recent meta-analysis of heart failure studies, the overall risk appears to be about 1.6 relative risk. But when they actually looked at the women versus men in these studies, the relative risk in women was 3.67, so almost more than twofold higher. And this is very interesting. Why is this? Heidi Crane, I think I see her. Yeah, there she is on the participant list. Published these data from CNIX in JAMA Cardiology a few years ago to show that type 2 MI is more common in women than men. You can see the proportions here. So not only is the risk higher, but the type of manifestation of the cardiovascular disease is different in women compared to men. We summarized this nicely in a review article we did for Current Opinion in HIV/AIDS for myocardial infarction, stroke, and heart failure. You can see the relative risks for males versus females in these studies. These are representative studies that we chose. And you can see that the relative risk of HIV versus HIV negative is much higher in women than in men. And again, whether this is true in sub-Saharan Africa, it's an interesting question to wonder about. So Markella Zaney at Harvard and Mass General Hospital has put together a nice way of thinking about mechanisms of risk in women with HIV. And we're going to talk today about systemic immune activation and inflammation, which is an important mechanism, we believe. But there's also the traditional risk factors and potential treatment disparities for women with HIV with regard to hypertension, dyslipidemia, or dysglycemia. And then certain behavioral and psychosocial factors, particularly they were writing this for North America, but perhaps relevant to mostly high-income countries. And then this idea of accelerated reproductive aging, which Markella has been investigating for some time now, which is the loss of endogenous estrogen and ovarian reserve, which seems to happen earlier in people with HIV and women with HIV. So all of these things obviously interact with each other to ultimately increase cardiovascular disease risk among women living with HIV. Now, in sub-Saharan Africa, it's unclear whether there may be actually different behavioral and psychosocial factors. In particular, we're interested in whether exposure to household air pollution, such as biomass fuel cooking, or physical activity patterns that are very different, could increase or decrease cardiovascular risk in women with HIV. So I like showing this diagram of how I think of HIV residual risk in 2022. The size of these buckets has changed over time, but now I think it's really traditional risk factors that ultimately drive a lot of risk in high-income country settings. And ART specifically, the days of worrying about the older protease inhibitors are relatively rare these days. But inflammation and immune activation has come to the forefront. And so we'll talk a little bit about that. And I love this slide that Peter Hunt put together and allowed me to use that just reminds us that we have a clue about the pathogenesis of HIV/AIDS from nature, which is if you have pseudomangabes that you infect with SIV, they achieve a high level of viral replication, but don't develop AIDS and have a normal lifespan, whereas a rhesus macaque is infected with SIV and has similarly high levels of viral application, but then develops AIDS and dies. So what is the difference here? And it's that the pseudomangabe is characterized by very minimal immune activation, whereas the rhesus macaque is characterized by massive immune activation and ultimately the pathogenesis of AIDS. So what about sex and inflammation in response to HIV infection? You may have seen this pictorial previously, but women have more interferon alpha and interferon stimulated gene upregulation with TLR7 stimulation by HIV. And this acutely leads to better control of the virus and generally less CD4 T cell loss. But chronically over time, it may be maladaptive from a standpoint of the chronic non-AIDS comorbidities like cardiovascular disease, kidney disease, et cetera, where inflammation is thought to play an important role. So also it's important to note that women appear to have smaller reductions in inflammation markers after initiation of ART. So we know that inflammation immune activation can drive atherosclerotic cardiovascular disease risk. This is a pretty old figure by now, but still holds true. And the point is just that it's not just the formation of a fatty streak and atheroma, which leads to subclinical disease that we can detect by ultrasound, but is otherwise not clinically relevant, but also at the stages of more advanced disease and the acute coronary syndrome or acute stroke that results from a plaque rupture and clot formation. So inflammation is important throughout this process. So in HIV, how do we investigate this inflammation CVD link? Over the last 15, 20 years, investigators have used biomarkers to characterize inflammation and imaging to characterize cardiovascular disease. In particular, there are some usual suspects, I'll say, in the soluble markers realm. There are others, but these are just a handful. And we've used flow cytometry, of course, to characterize different T cell subsets, monocytes. People have been very interested in this, in particular for cardiovascular disease. And then from the cardiovascular imaging standpoint, throughout my career, I've done all of these things, working with Grace McCumsey, Jim Stein and others, doing brachial artery reactivity testing, carotid ultrasound, carotid intima media thickness, or looking for plaque in the carotids. We've used endopat machines. We've used FDG PET CT and echocardiography, but increasingly, I think that it's really the advanced cardiovascular imaging modalities that are most useful to use to study the kind of the mechanisms of cardiovascular disease in HIV. The problem is that these studies have all been done in high-income countries, and this was published in JAMA this summer by Anup Shah, the same guy that did the meta-analysis of the global burden of HIV-related CVD. And you can see that all the advanced imaging studies in this systematic review come from high-income countries, the majority from high-income countries, and some from middle-income countries, but no studies from low-income countries. Now, they cut their data for this review, I think, right before our study on CT angiography from Uganda was published in January, but nonetheless, ours is the first one from a low-income country. So I think this is very important to consider as we move forward. I'm going to talk a little bit about this study that I'll call the Mutima CT cohort study, which is 100 people with HIV and 100 age and sex matched controls in Kampala, recruited from the JCRC. And you see Dr. Sissy Kiccio, who many of you know, who was my co-principal investigator on this study. All were over 45 years of age with at least one risk factor, recruited over a couple years from 2015 to 2017, and we invited them back for another exam between 2017 and 2019. So the assessments included a bunch of things, but coronary calcium scan at baseline and the CT angiogram at year 2. This is us in the control room of the CT that we use at Insomnia St. Francis Hospital in Kampala near the US Embassy. Some of you may know Mark Seidner here, a good friend from MGH and Harvard, who's doing work with us using a cohort that he has in Mbarara in rural southwest Uganda. And then others here, CT experts from around the world, helping to build the capacity to do this work in Kampala. As a review for those who are less familiar with cardiac CT, there's coronary artery calcium, and then there's CT angiography. Coronary calcium can be obtained simply from a non-contrast gated CT scan. Apologies there. Whereas it requires contrast to see the lumen of the artery, as you can see here. So this is CT angiography. CT angiography can also characterize the plaque burden, can quantify the plaque, can describe it in terms of calcified versus non-calcified and other high-risk plaque features. So our first study, importantly, described the distribution of coronary artery calcium amongst this population of people living with HIV and controls in Uganda. And what was very interesting to us when we published these data a couple years ago now in comparison to our Cleveland cohorts, very similarly aged. And actually in Cleveland, they had less risk factors, less uncontrolled hypertension, less uncontrolled diabetes compared to the Uganda cohort. And coronary calcium was just much more common in Cleveland. And in fact, after adjusting for age, sex, diabetes, hypertension, smoking, and cholesterol, Ugandans had 13-fold lower odds of coronary calcium. So this was a very interesting finding to us. But when we broke it down by women and men in this publication from earlier this year, we can see that for men, it follows, the calcium distribution follows the expected association with ASCVD risk. So those who have a greater than 10% 10-year risk of an acute ASCVD event had the most coronary calcium. Whereas for women, it's interesting, you saw coronary calcium across the whole gamut of ASCVD risk. So really not as closely associated with traditional risk factors. And if looked at as another way, as an ROC curve, with traditional risk factors, ASCVD risk score as a predictor of coronary calcium, the area under the ROC curve was 0.79 for men, but for women was only 0.58. Adjusting for HIV did improve the prediction of CAC in women. So we then invited all of the 200 participants from the baseline exam to return, and about 75% of them did. We replaced them with some new subjects so that we could have a matched cohort of 200 people again at year 2. And then we have ultimately 165 of them that were able to have a CT angiogram. As you know, if you have poor kidney function, if you're too tachycardic, this can lead to technical problems with CT angiography. We quantified the plaque burden not by quantitative angiography, which is very difficult, time-consuming, but rather by this grading system that gives each plaque a score of 1 in the segment involvement score. And as some of you may know, if you take the 3 main coronary arteries, the RCA, LAD, and left circumflex, divide them into segments, we have this 16-segment model that we use in cardiology. So you could have potentially 16 segments that were diseased. If you then weight the severity of the luminal stenosis, you can see that you could generate a weighted score where a more severe obstruction is given a score of 3 or 4, and you can get a segment stenosis score out of 80. So if you look at segment stenosis score in our population, the median was 3. So when we looked at those who had 3 or less versus those who had 4 or more, we see that although there are kind of less people with HIV who have like mild disease, there was actually an increased risk of more severe coronary artery disease in people with HIV. And what was really important to us is to look at whether or not this the plaque morphology is similar to what we see in the US. And we found that actually the distribution of plaque type by calcified versus non-calcified was really not that much different between people with HIV versus without HIV. And you can see that 2 different ways here: non-calcified, partially calcified, and calcified plaques. But the sex interaction still persists, and these are many of the same people who participated in the baseline exam, but also some new ones, and ultimately about 60% female. We see that for people living with HIV, females actually had more disease than men of similar age. That is not what we see in the United States. Whereas we do see the typical in people without HIV, more disease in men than women. And after adjusting for age, sex, HIV, and ASCVD risk score, the P for interaction here was 0.019. So what about women with HIV, and particularly in sub-Saharan Africa, what might be going on? And I think I want to focus a little bit on inflammation and immune activation. So we can see the effect of sex on soluble CD14 in Uganda from this paper by Mark Seidner and his Mbarara group in 2018. You can see that women have higher soluble CD14. They have higher intestinal fatty acid binding protein. And if you look at this kind of chart of soluble CD14 in his study versus ours, which is not published, but very, very similar. You see higher soluble CD14 overall in women, and there certainly is an HIV effect. We, as I said, also looked at markers of monocyte activation and did fresh whole blood flow cytometry, looking at inflammatory monocytes, the CD14, CD16 double positives versus patrolling monocytes. And we see the typical association that has been described elsewhere around the world, where people with HIV have more inflammatory monocytes. But we actually didn't see any effect of sex on inflammatory monocyte profiles in these studies. Now, we were also interested in whether these monocytes profiles are associated with latent tuberculosis. We have another paper on that if you're interested. Coronary calcium at the baseline exam in Mutima was associated with a variety of different inflammation markers. And in multivariable adjusted models, you can see that a number of them were statistically significantly associated. And so we were very interested also to look at whether baseline inflammation markers, so we had these markers at baseline, but unfortunately do not have them at the year 2 exam due to cost. But Sateh Shakil currently has this paper under review, which is looking at females and males separately, and showed that the several markers, particularly TNF-alpha receptor and soluble CD163, were associated with coronary artery disease 2 years later in females, but not in males. And the sex interaction was statistically significant for a number of them. I'm just going to very briefly show these data on the monocyte subsets. In addition to the 3 main kind of categories of monocytes that you've probably seen, we looked at a couple of other markers, including CD69 and the fractalkine receptor, CX3CR1, and tissue factor and HLA-DR. Didn't really find the expected relationships or associations with disease, and in fact, in a couple cases, found correlations between like the fractalkine receptor and negative correlation with coronary disease. So we're exploring this further by looking at these markers within different subsets of the inflammatory monocytes, but more to come on that. Importantly, there were no sex differences here. Another line of investigation that we have pursued because of the unique nature of our population and the high prevalence of latent tuberculosis infection, we based on some epidemiologic data that LTBI is associated with increased risk of myocardial infarction and stroke. We wanted to see and see whether it was associated with coronary disease phenotypes in our cohorts in Peru and Uganda. This is my colleague at the University of Cincinnati, Moises Huaman. Some of you may know Moises through the ACTG. He now has an R01 that I'm partnering with him on to look at the treatment of latent tuberculosis and whether that affects coronary artery disease progression over time. This work from our own Tekla Temu, I'm not sure if she's on, I don't see her, is currently under review, but she gave me permission to share, shows that the immune response to LTBI is definitely stronger in women with HIV compared to other groups. Excuse me. If you look at IL-12, for example, as one example, you can see that women, HIV-positive women with HIV, really have the highest association with this biomarker compared to men. And so we're very interested in pursuing this further in all the variety of different LTBI studies that are ongoing. Let's talk a little bit more about heart failure. I mentioned that fact that in the meta-analysis of heart failure risk, that women had a much, almost threefold higher risk, HIV-associated risk compared to men. Why might that be? And I think this was a really nice and beautifully done study by Priscilla Hsu and the UCSF group that they were able to get access to people who died of sudden cardiac death in San Francisco and then do autopsy. And they were able to describe that for HIV positive persons who died from arrhythmia or from other non-arrhythmic cause of sudden death, they had much more fibrosis, as you can see here, the blue interstitial fibrosis between the heart muscle cells compared to people who died of sudden cardiac death who did not have HIV. This is true for the interstitial fibrosis, but also for replacement fibrosis, which you can see when you have focal myocarditis or you have a myocardial infarction. So we believe that this may be one of the things that's happening upstream, which ultimately leads to diastolic dysfunction and systolic dysfunction that leads to heart failure. How can we see this? Because we can't do an autopsy on everybody. How can we see this non-invasively in order to conduct these sorts of studies? Well, it's really by MRI. And this is a colleague of mine collaborating on a new grant opportunity at the University of Cape Town, Professor Ntobeko Ntusi, who has done a lot of this work showing that there is more replacement fibrosis as detected by MRI in people with HIV, but also this interstitial fibrosis, which we measure on MRI with something called extracellular volume fraction, or ECV. You can see ECV here along the y-axis in these data from the Harvard group, Markella and company, showing that women with HIV appear to have more diffuse myocardial fibrosis and worse diastolic function compared to HIV-negative women in this small study. Importantly, they looked at markers of inflammation and found that certain markers did associate with more diffuse fibrosis and inversely with diastolic function. In Ntobeko's South African cohort, we see that actually there is the same sex interaction that we saw for coronary disease, where it's really women with HIV who have the most diffuse fibrosis. This is extracellular volume fraction. Again, of 31, which is pretty significant. It may not seem like a big difference, this too, but this is, if you look at the standard deviation, this, there's really not a significant variance in this measure. So 2 percentage points is a lot. And so we have not yet been able to do cardiac MRI in Uganda. We hope to be able to do that soon with grant funding. But in the meantime, we have used echocardiography to look at some of these things and have described in this Jaha paper biomarkers of cardiac stress and fibrosis, and measures of cardiac stress and structure and function, and looking at the sex effect and whether there's effect modification by sex for the HIV effect on these things. We do see that the certain traditional cardiac biomarkers that tend to be higher in men, like ST2 and cystatin C, a kidney filtration marker, were indeed higher in men compared to women, and LV mass index, which is definitely tends to be lower in women, also lower in women. But interestingly, despite having lower LV mass index, women had more diastolic dysfunction compared to men. But when we looked at LV mass as a kind of a surrogate marker, because the way you measure LV mass on echo is just by looking at the heart muscle that you can see. You can't tell the difference between what's actually myocardium and what is that interstitial or extracellular volume. So we think that the association of HIV with LV mass may be driven mostly by that ECV association. But when we looked at LV mass and biomarkers, we saw that they were more strongly associated with LV mass in men compared to women. Excuse me. So all that to say that sex certainly affects risk in people with HIV, but what does that mean for prevention? And so as many of you know, I am very interested in trying to test strategies to improve cardiovascular care for people living with HIV. And I'm a strong believer that it's now time to extend the HIV treatment cascade for the prevention of non-AIDS comorbidities. And in terms of atherosclerotic cardiovascular disease, it really is hypertension and hyperlipidemia as the #1 and #2 risk factors together with smoking in our North American population. So we first have to diagnose hypertension and hyperlipidemia, then need to manage it appropriately with medications, and then aggressively titrate those medications to reach blood pressure and cholesterol goals. Well, how do we do that in the HIV treatment context? And is that different in the US versus in Uganda? And is it different for men or women? We're exploring these things and these questions in 2 NIH-funded trials. This UA one is called Extra CVD, a nurse-led intervention to extend the HIV treatment cascade for cardiovascular disease prevention, being conducted in 2 sites in Cleveland and 1 site at Duke. We have then another cluster randomized controlled trial of 16 clinics where we're going to test in a stepped wedge design a high intensity, kind of high touch strategy of integrating hypertension care into the routine HIV care in Uganda versus a more low touch strategy of simply providing antihypertensives and blood pressure machines. A lot of lessons have been learned, and it's just fun being part of 2 projects that are similar, where we can kind of share learnings across the 2 projects. We call this reciprocal innovation. But some of the things that are part of both of these projects include task sharing and using nurses and other healthcare workers to do things to really overcome the clinical inertia that we prescribing physicians sometimes have. And then the way we designed these interventions was really through a stakeholder-informed, human-centered design approach, and happy to talk more about that. But another key component that we ultimately decided was important is remote patient monitoring and monitoring in the community using differentiated service delivery models for doing that in the community in Uganda. So more to come. There's no results yet from these trials. The Extra CVD study will finish follow-up at the end of the year. So we hope to have results next year. And we're just getting underway with the cluster randomized trial in Uganda. So some take-home points, and then hopefully I've left plenty of time for discussion here. So HIV does appear to be associated with a higher risk of cardiovascular disease, and this is particularly true in women. Both the HIV and sex effects may be partly due to inflammation, as we've discussed, but also other non-traditional environmental risk factors, and we're very keen to explore those further in sub-Saharan Africa. We believe that novel strategies to reduce risk should be developed with sex and gender-specific needs in front of mind, when we get to that point. And ultimately, the goal is to improve cardiovascular disease outcomes for all people living with HIV in all contexts around the world. So I'll thank all of my collaborators, not all of them listed here, but some of the main ones. Really appreciative of the funding and especially research staff and study participants. So thank you very much.
Thank you so much, Dr. Longnecker. That was a great talk. For anyone who has questions, you can either put them in chat or you can raise your hand and I can unmute